This is going to be a bit of a narrative presentation, which is something a departure from what we often do in medicine and science, right? A lot of everything we do is didactic, but narrative medicine is actually a burgeoning field, and so this is going to be a narrative presentation. I want you to ask questions. You can ask during the presentation. If it's easier afterwards, we'll definitely have a Q&A. And so I wanted to first introduce myself as I am late deafened, hard of hearing. I started to lose my hearing at age 35, and it's been progressive, and will likely be progressive. And so I wanted to share some of my insights as to what I do day to day as a gastroenterologist and a transplant hepatologist. And then we'll talk a little bit about my journey from the start, really, to where I am today. So an outline of what this talk is going to be about. So I will absolutely be talking a little bit about just my day-to-day life as a liver doctor and what that entails. I wear several different hats like many of us do, and so we'll talk a little bit about that. And then I'll talk a little bit about my journey and ways that I've been able to overcome barriers, the mitigators in my life. And then a little bit about medicine as a field and the ableism that exists in medicine, and some of what I've been inspired to hopefully try to change and the advocacy efforts that myself and others in this field are doing, and kind of future directions. I have no financial disclosures related to this talk. So a little bit about how much training and education went into becoming a transplant hepatologist. So I hail from Gaithersburg, Maryland. I went to the University of Maryland for undergraduate in biochemistry and molecular biology. And that is 4 years, pretty standard for most BS programs. Then I decided I wanted to go to medical school to use some of the critical thinking skills that I learned as a biochemist to help people in a clinical way. Medical school is typically 4 years. And then I decided I wanted to do internal medicine, which is kind of I think, the foundation of medicine. It's a general medicine. So if you go see a doctor for a cold or a sore throat, that's the kind of medicine that internists practice. And so that residency is 3 years in length. And then after that, I decided there are different subspecialties within internal medicine, more than 10 really, but I decided I wanted to do gastroenterology and hepatology. And so that fellowship, it requires further subspecialization, and that was 3 years. And then I decided I fell in love with the liver, and I wanted to do an extra fellowship in liver transplant. And so I went back to the University of Maryland, and I was there for 1 year doing that fellowship. And so in all, 16 years later, I get to practice independently on my own. So what does a typical day in my life look like nowadays? So I mentioned that I was late deaf and hard of hearing. I wear hearing aids, and so recently have upgraded to micro mold and hearing aids. This is absolutely essential in my day-to-day life. I also use a Roger mic and a mini mic. And so when talking to patients or talking to my learners, I'll often either point the mic at them, give them the mic, clip it on their lapel while we're rounding in the hospital, or in a procedure room, I'll have it clipped to one of my nurses who might be talking to me to help amplify directly into my hearing aids what they're saying. I use a stethoscope. There's 2 different ones I have actually, but this is my favorite, the ThinkLabs Bell stethoscope, and it actually can connect to over-the-ear headphones. It can also stream directly to a Bluetooth speaker. And so I'm able to I can even have my patients hear their own heart sounds and their own lung sounds when I do that. And ever since COVID came around, virtual meetings became much more of a thing. And in order to be able to survive virtual meetings, auto captions, live captions have been an immense help. This is me and my husband and a few other docs at work talking after a meeting is over. But just to give you an example, and this was not widely available in the middle of the pandemic for all systems. And actually the system I was working for didn't have auto captions. They opted for a software that didn't have it enabled. And so this was one of the things that I advocated for. And then the other thing, I actually use lip reading in part to help myself be able to access what information people are saying to me. And so with COVID, we had a year and a half where we were mandated to wear masks in the hospital setting. And so they actually had clear masks prior to COVID, but they started manufacturing them much more robustly during and after COVID. And so I actually use clear masks, and for my patients who choose to mask, I often will ask them to change over to a clear mask, and if they need me to change over to a clear mask, I do so as well to help augment my access to them. And then I also use people. One of my clinics, my pre-liver transplant clinic, I have a nurse in my clinic visit. We all do, actually. But Megan is immensely helpful if I am not hearing or understanding, or I've misread a signal from a patient. She will flag me down and let me know. So Megan's been immensely helpful. And then I have trainees under me. So as a teaching institution, I teach other doctors that want to be a gastroenterologist and a hepatologist under me. And so they're often with me in the clinic spaces or in the inpatient setting when they're rounding in the hospital or in endoscopy. And so they're actually there as well. And many times, I'm very open about my disability. And so they know I can't hear as well, potentially. And so they will correct me or point things out to me as well. So it's been a great collaboration partnership. And so what does my typical schedule look like? So most weeks out of the year, I am in what we call an ambulatory setting or an outpatient clinic building. But about 12 weeks a year, I'm also on the hospital wards. And so the rounding weeks are typically 7 days in length. And then the ambulatory weeks are typically Monday through Friday. And because I'm also a gastroenterologist, I do endoscopy, or I do scoping. So part of the time is not just in clinic, but I'm also scoping patients. And then, again, I work at an academic institution, so teaching is a big part of what I do. I actually precept our fellows clinic, and so I'm involved with that on a day-to-day basis, whether it's high school, college, medical students, residents, fellows. And then leadership. I've had the opportunity to be a part of several of the committees at our institution, as well as nationally as a part of our societies. And so I've been hoping to help lead the way for various projects. And then one of the reasons I actually left Detroit to come to Indiana was because I wanted to focus more on research and go back to kind of my biochemistry roots in just a slightly different way. I don't work in the lab anymore, but doing more of a clinical research twist. So this is an old picture. I'm not this young anymore. This is me in my internship. We are not always this happy rounding in the hospital, but this is the main hospital I work at in downtown Indianapolis University. And this is just to give you a sense of what my clinic weeks look like, my ambulatory weeks. And so typically 3 half days of clinic, and then the rest of the week is scoping and precepting clinic. And so what are some of the things a liver doctor might talk to patients about in clinic visits? So the clinic visits can be something as little as, we're having conversations about talking about somebody's fatty liver disease, so abnormal liver tests because of extra fat in the liver, which can happen usually when they have a trifecta of things like diabetes, high blood pressure, high cholesterol, and being overweight. to things like end-of-life talks. Sometimes my patients with liver disease, when we do not have transplant as an option, talking to them very frankly about what does the rest of the time that they have left look like, and how can we help make the best of it. We also talk about, obviously alcohol is one of the culprits for liver disease, but it's definitely not the only one. And fatty liver disease is actually beating out alcohol on all fronts. But having a frank conversation about alcohol, not being afraid to have that with my patients, and just, counseling what healthy use is versus unhealthy. And then many times, my interest actually is pregnancy and liver disease, and so I have a women's clinic where patients who are pregnant, who have developed a liver disorder that only happens in pregnancy, or patients who've had liver disease who are pregnant, or patients who are after a liver transplant who get pregnant, we have to monitor these patients much more carefully, and so I help work with the maternal fetal medicine specialists, as well as the OBGYNs, as well as primary care, to make sure that they have a successful outcome. So we are still technically in March, and March is Colon Cancer Awareness Month. And one of the big things that I do as my job is also to make sure that people are doing their preventive health maintenance. And so no longer is age 50 the recommended time that you require a colonoscopy for screening for colon cancer. It's 45, so I remind people, and we make sure we set people up for that. And then a little bit about scoping or endoscopy, as we call it. So as gastroenterologists, we can reach most of the GI tract with our scopes. As you can see here, our upper scope can go all the way a little bit past the stomach into this first part of the small intestine. And our colonoscopy scope can go all the way around the colon, and actually can go into the first part of the small intestine. There are about 3 meters of small bowel in between that we can't directly reach with our scopes, but we have little pill cameras that people can swallow, and we can record, and we can look to see what's going on in that area if we need to. And this is kind of an example of what my endoscopy cart looks like. Typically, I'll have the patient here, a monitor on the other side, and the cart behind me. And this is what an upper scope looks like. So we have the dials, and then we have a long, thin tube, and it has a camera and a light at the end. And the magnification on that camera is significant. So little things look really big, but it's very helpful for pathology. So the next few pictures are going to be potentially a little gruesome. This is the least of the gruesome ones. So this is actually me looking inside somebody's stomach who came in with abdominal pain. And you see this outgrowth is not normal. And so we ended up snaring it and taking it off. Thankfully, this was benign pathology, so not cancerous. But this is some of the things that we do. And then obviously colonoscopies, trying to prevent colon cancer, but also doing it if someone's having particular symptoms, whether that's bleeding in their stools or abdominal pain, or a change in their stool character. And so this is typically what normal polyps look like. So you can see that small little outgrowth that's popping out of the colon wall. This is a patient who I scoped about 2 weeks ago, who had a markedly larger polyp coming out of the wall of the colon. When we actually took it all out in one piece, so it was about 2 centimeters. And so just for a frame of reference, most of the polyps we remove are anywhere from 2 to 10 millimeters, so a lot bigger. So we put this device as a snare that we can actually snake down through that tube, and the little lasso comes on at the end. We're able to put it around the polyp, and then I have a tech who kind of deploys the snare, and it tightens up right around the polyp, and we take it off, and it looks like this, very satisfying afterwards. It's all gone. And sometimes there are a lot of blood vessels that can feed those polyps, and so you can get bleeding. And so this patient in particular started to have bleeding right from that area. And so we actually were able to put clips that are about the size of just the top part of my pinky over that area, close down on that, and that causes hemostasis and kind of allows for that area to heal, and as it heals, that clip will fall off and gets pooped out. So other things I do, because I'm a liver doctor, as well as a gastroenterologist, I take care of patients with advanced scarring in the liver, cirrhosis. And one of the things that can happen when you have so much scarring in the liver is it's difficult for the blood vessels that are existing in the liver to have blood flow go through them. But blood will find a way, has to go somewhere. And so our body naturally has blood vessels in different parts of our GI tract, and we all have blood vessels in our esophagus. And one of the complications of cirrhosis is that backup of blood flow, those esophageal veins will become more engorged than they should be. And so they become, we call them varicose veins or varices. And so with every patient that has cirrhosis, we actually have to do a screening endoscopy. And so that's one of my jobs. And so this is actually a picture of me looking with that camera scope down someone's esophagus. It should look like a tunnel, but it doesn't, right? It kind of looks like a cave. There's all sorts of projections coming into it. And this is a little bit better of a picture here, but these are actually blood vessels. So 1, 2, 3 columns is what we call them of esophageal varices. And if you look really closely, there's these little red spots on them. I call them red well signs. And those actually mean that there's significant pressure behind those varicose veins. And so I have to intervene when there's significant pressure because those could spontaneously burst and bleed, and it would happen at any time potentially for the patient. And so we actually deploy another tool through the scope that at the end has rubber bands, and they basically, I can suction up that esophageal varix into that part of that, we call it a bander, and I can twist off and deploy that rubber band. And so this is just a regular rubber band, like our hair rubber band, but it ties off that blood vessel. And if we do this several more times, over time, we can, and yes, you do get some bleeding and oozing with it. You're manipulating blood vessels, so that's to be expected. But this actually was a way to prevent further bleeding. And so most patients have to come back 2 or 3 more times. And I have to do this procedure a few more times to get that to go away. But this is a preventive procedure. So other things that bleed in the stomach, there are many, but I figured I would present you with things other than just ulcers. And so this is actually a phenomenon called an angiodysplasia or an angioectasia, which is a collection of blood vessels that can form in this wall of the stomach lining, and those can bleed if anything goes by it. So you can imagine you're eating food all the time, and the stomach is a muscle, and it's contracting all the time. So this usually causes a slow bleed. It doesn't cause like a massive hemorrhage, but a slow kind of bleed that leads to anemia. And that can be pretty significant for people. And so one of the things we can do is we can actually put a probe through the scope again, and at the end of it, we have a little laser beam. And so I was able to use that and burn off this blood vessel. And then this was the size of that little clip that we mentioned before. I can actually open that clip up and deploy it at that spot. And this person had to come back 2 or 3 more times for a kind of elective treatment and retreatment of that site. But we finally got that angioectasia to go away. So moving on from endoscopy, so some of the teaching and leadership, I do get to give talks at national conferences for my teaching, or for my liver society, so the American Association of Study for Liver Diseases. And so this is me last fall giving a talk, organizing a symposium for teaching actually. And this was just an example. We have over 8,000 international and national attendees. I think only 100 or 200 came to this talk, but this is one of the fun parts of my job. And then, I mentioned that I had started to lose my hearing when I was in training. So what are some of the things that I had to do and those around me had to do to kind of adapt to my hearing loss? So probably nobody knows what this is anymore, but we actually used to use pagers for everything all the time. And nowadays our phones are pagers, but in most places, but there are some hospital systems that still use these. And so I would be on call at night, and of course I take my hearing aids out at night, and I sleep like a rock anyway, and so I was very worried that I would miss these phone calls and these emergency calls in the middle of the night. So they actually have a device that is a dock that is an amplification device, and so you can put the pager in the amplifier and crank up the volume, and that's what I did. Nowadays, I'm still on call at night, but what I do is I have my phone, set to a high ring, and I have my Apple Watch on, and so I actually have an away message up on my paging software that says you have to call me. You can't text me to try to wake me up at night. But then my phone buzzes and my watch buzzes, and I wake up and I'm able to answer calls that way. And then the other thing, back when I first started to lose my hearing, Medicare did not cover hearing aids. Not that it covers them well currently, but it was not a covered thing. And so as a resident, you're making a less than minimum wage salary for the amount of hours we work. And so I could not afford $5,000 to $6,000 hearing aids at that time. And so one of the ways that I was able to adapt was Costco had partnered with various hearing aid companies, and at that time it was Resound, and I was able to afford bilateral hearing aids for markedly less than what they cost if I went to the audiologist to buy them. And so that was actually one way that I was able to adapt, because I would not have been able to make it through the rest of residency without them, but this helped me. So the other hat I wear, I'm a transplant hepatologist, and what that means is I'm not the one doing the surgeries, though that is part of my training. I have to be in the OR, I have to participate, I have to help with the surgery so I know what my patients are going through, and how fit they have to be to get through it. But what my job primarily when I'm in my transplant clinics is to try to get people to the transplant table. And so to keep them medically well enough to be able to survive to transplant, and to get them through the rigorous testing that is required for patients who are undergoing transplant. Transplant operations are, back when I was in training, would take somewhere between 10 to 12 hours. So it is a long operation. Nowadays, with many advances that I'll talk to you a little bit about in the next few slides, it has shortened to about 2 to 4 hours, but it's still a really stressful surgery on a body. There are big shifts in blood pressure that happen. There's a lot of blood products people have to get because there's a lot of bleeding that happens in the OR with these procedures, with this surgery. And so we put people through really rigorous testing to make sure that they are going to survive being on that table. And so that's part of my job. And then so there's two kind of ways people with liver disease present. They can present in a chronic state of liver failure, and then I usually have a little bit of time to get things going and get them to this place. But they can also present all of a sudden with liver failure. And so that's part of why I do inpatient rounding, is because when those patients all of a sudden come into the hospital, I'm actually taking care of them in the hospital and trying to expedite this route for them. So this is a lot. This is what happens when they come into the hospital with acute liver failure. And I won't go through it all, but this is in large part my responsibility, as well as the ICU doctor that I'm working with, because almost all of these patients are in the ICU when this is happening. And so we take care of all these different systems that are failing and try to keep them afloat until we can get all the workup done to get them on a transplant list. So this is what it looks like when someone's liver has advanced fibrosis or cirrhosis and they have removed it completely. And this is what a beautiful donor liver looks like. This is a whole liver donated from a deceased donor. And this is what that liver looks like in the person's body now. It's perfusing blood. You can see it's gotten red and it's working. And many times when patients' livers fail, their kidneys also fail. And so we actually do what we call simultaneous liver and kidney transplants many times. And so this is just a picture of a beautiful kidney with the ureter coming out of it that we place in addition to the native kidneys. We almost never take out the kidneys that people are born with that aren't working well. We'll put an extra kidney in there. This machine is, there are many varieties. This one's Organox, but there's 2 or 3 other companies that make this. In the last 2 to 3 years, the transplant community has learned that previously when we had a donor organ, a donor liver, we would just be pumping through saline, it's actually a Wisconsin solution is what it was called, and then putting it as quickly as we could into the recipient. In the last few years, we have learned that if we actually pump blood through that donor organ in a circuit, like with this machine, that it does better when we put it into the recipient. And so this has helped us significantly to reduce that OR time, but also be able to use many more organs, because sometimes we couldn't, you know, if you're flying to California to get an organ and we're in Indiana, sometimes the amount of time it takes to get that organ out of the donor, to fly it back, was just too long and we couldn't use it, right? But this has helped us to use more organs, and so this has been a big improvement. And then I want to talk a little bit about how amazing the liver is in terms of how it can regenerate. So we currently use whole organs from deceased donors, and we give them to patients who need it. But we can actually also split the organ and use just part of it. And it will regenerate to nearly full size by about 3 to 6 months after transplant in the recipient. And so this has led us to be able to actually also do what we call living donor liver transplants. So we can take all of the old liver out of the person who needs it and give them just half of a liver of someone who's living, who's either a family, friend, or we actually have altruistic donors too. So people who don't know the person but want to donate, want to help. And so we can give them half of their liver, and in both the donor and the recipient, the liver grows to nearly full size by about 3 to 6 months. And so this here is just a graphic to kind of show how many liver transplants do we do in the US. And this is slightly old numbers, 22 to 23, but almost 9,500 liver transplants were done in 2022. Of that, 600 were living donor liver transplants. And also you can see that there are about 526 pediatric liver transplants done. So this is how many last year IU did. So Indiana University did 215 liver transplants, the most we have ever done in a single year in the history of the program. And nationally, we did the top number, we were 5th in terms of numbers of liver transplants done in the country. So a busy center. And nationally, in the last year, we don't have all of the breakdown of the stats yet, but nationally, more than 10,000 liver transplants were done. It's the most that have ever been done in the US. And I think in part related to the living donor liver transplants that we're doing in much more frequently now, but also because we are able to use so many more donors with the perfusion technology that has kind of come about. So part of when I mentioned that I do inpatient rounding, this is actually my rounding team structure. So I have 16 spots on my team. I typically have 2 interns, and 1 senior resident, and I have 1 of my fellows on that team. And so I'm usually, myself or one of my partners is the attending, and because we have these 16 slots, we're able to take in patients who are either chronically ill with liver disease and kind of expedite their transplant evaluation and workup, or take people who are acutely having liver failure. And I think that this is in part why we've been successful and why we've had so many transplants in the last few years at IU. And then this is just to introduce the rest of my core team that I work with. So Dr. Cabal is actually the lead transplant surgeon. Him and 2 other surgeons work together. Dr. Lacerda is our medical director of liver transplant, and he kind of leads the team of the rest of us who are all transplant hepatologists who work together to help save these lives. So that is a little bit about what I do day to day. How did I get here? So I wanted to talk a little bit about my journey. So I was born here in the US, in Maryland, to immigrant parents. They had come about probably 1 to 2 years before I was born into the US. They spoke only Hindi, and all of their friends that they knew here only spoke Hindi. And so when I was born, I only spoke Hindi. I have a twin brother, and so we also had our own language that we spoke that nobody understood other than us. But I'm a non-native English speaker. And I started school and learned English through ESOL. And then partially probably also because of some of the language barrier, nobody realized, and I didn't realize until I got into public schools, that I actually couldn't see. I was always getting chastised for sitting very close to the TV at home and being told to sit back, but the reality was I couldn't see much further than in front of my face. And so I was diagnosed with near legal blindness, obviously used corrective lenses, but that was a delayed diagnosis, which did delay my learning of several other things. And we, as immigrant families, many immigrant families do, we lived below the poverty level. So we were technically well below that line and stayed below that line for most of my childhood. And then at age 15, when I was in high school, I was actually diagnosed with inflammatory bowel disease. And so that is an autoimmune condition where your immune system attacks your colon and things that shouldn't be there. And so it causes a lot of destruction and a lot of pain and a lot of bleeding and all sorts of symptoms. And so I was diagnosed at age 15, told at the time, well, there's no way, given how severe your bowel disease is, that you're gonna be able to go on and do things like graduate education. And so despite that, with some of the mitigators that I'll talk about as we move forward, I was able to get through graduate medical education. And then while I was in graduate medical education, I developed bilateral sensorineural hearing loss. Not completely clear what the etiology is, but they think that it's likely also another autoimmune disease. But it's kind of been progressive, and at the same time, because there are several autoimmune conditions that kind of run together, I was tested from a vision perspective and also found to have retinal vasculitis, from which I'm thankfully asymptomatic. All right, so a little bit more about my journey. This is my husband and my 2 kids. I wear many hats, not just at work, but also in my life. So I'm a physician, I'm a mom, I'm a daughter, I'm a forever learner, and I'm a wife. As a part of my journey, what were some of my barriers, and what were the things that helped to mitigate them? So finances, we lived well below the poverty level for a long time, and so I didn't have the luxury always of being able to pay for tutors or pay for SAT classes or pay for some of these things that a lot of the friends that I had we lived in a very affluent county were able to do, and so that was a barrier. we had ESOL where I was, and very thankful for it because it helped me to learn how to speak English and read and write English by about grade 2. I was able to do those things. I was also born into a county with lots of resources. So Montgomery County, Maryland, it's one of the top school districts in the country. And so I think as a big result of this, we had a very vibrant ESOL program, and they had so many resources. And I think this really was a big mitigator for me. Obviously, getting diagnosed with any chronic illness can weigh you down. And while it bummed me out for a few years, resilience. I actually got a full ride to several colleges, but University of Maryland, Baltimore County is where I ended up landing. Will never regret that decision. Had a lot of support there. And not only did I get into the college, I also got into the Meyerhoff Scholars Program, which is a program actually designed to help increase minority interest in STEM fields. And so there was a lot of extra support built into that program. We had counseling, we had our own financial aid counselors, and we had tutelage from older Meyerhoff scholars who would come in and kind of advise us on what courses to take or what not to take and which professors to avoid potentially. And then in my last year of college, we had a death in my family. My aunt, who had been one of my biggest supporters, died of metastatic colon cancer at the age I am today. And it kind of tore through my family. In an Asian family, that nuclear family is way more than just mom, dad, brother, sister. And so this had potential to deter me from graduating on time and doing all the things I needed to do. But instead, what I did was I kind of took a look at everything, and realizing how my family unit was doing, I chose to defer my medical school matriculation for a year. So I had put forward all this money to apply for that first round of medical school applications, and then I just realized I had to withdraw and do it, for the next year. But I got into University of Maryland, my top choice, and the next year. And despite that seeming to, in my mind, that was such a big glaring, I have this year gap between college and medical school. Everyone's gonna ask me what I was doing, why did I do this? And it was a totally nothing burger to all of the places I went to interview. It was really not a big deal. And especially because I got to do things that helped kind of enrich my life in that year, not just taking care of my family. I got to co-teach high school chemistry. I got to, do other things, and so nobody was upset about that. And then, while I was in training, I did develop hearing loss. This was actually a few years ago when my hearing wasn't as bad. This is a real audiogram. It's much worse now. But developing hearing loss, which then I felt like just yet another thing that kind of came my way, and now I have to overcome this and adapt. But it's been a gift in that it's given me a completely different perspective, other than just somebody who already had a chronic illness and knew what it was like to be a patient. Now I had a disability and understood from my patients' perspectives what that meant. I actually, when I was diagnosed with hearing loss, I was at the University of Cincinnati, and I had some amazing advocates in that program. My program director was very supportive and kind of said, if you need to go and drive for appointments or do anything you need to do, we will allow it. So that was a big blessing and a big mitigator. I also had an employee health physician who was had to evaluate my competency and for being able to continue in training. And she was a major advocate. She kind of gave me a carte blanche. Yes, she can do all the things. These are the things we're going to do to help her adapt. And yes, did I have to come up with some of those accommodations and adaptive devices and ideas? Yes, but I had people behind me the whole way. And then for a lot of us, COVID hit, and that seemed to be yet another setback in all the things. You know, for me, because I did rely a lot on lip reading, and there weren't clear masks at first, and masks in general muffle voices, and so that was a barrier. The health system I was working at the time really had no sensitivity to pregnancy, which I was pregnant with my first child at that time, and patients who were chronically immunosuppressed like I was, or providers who were chronically immunosuppressed like I was, and also just we didn't even have captions. We had virtual meetings, Skype meetings with no captions, and trying to advocate for that, for not just myself, but for all the other employees at my institution was difficult. But that threw several more barriers into the mix. So that was the system I was at. But clear masks came around, and that made life a little bit better. I was able to advocate for the captions and get them after a year. And then being a female, right? A female in medicine, in a field that, while I don't do surgery myself, it is chronically, I am always collaborating with surgeons and with interventional radiologists and with personalities that they don't see a lot of women in that field. Actually, when I was training as a gastroenterologist, hepatologist, I had no other female faculty in my division at the University of Cincinnati at the time. Me and my 3 other co-fellows that were female were the only female influence in that division. So gastroenterology in general still does not have a high predominance of female gastroenterologists because it is one of the more procedural fields, and there tends to be a lack of women going into it because they don't feel supported per se. My kids have been a constant source of joy, sleep deprivation, and sometimes stress. But this year, for overall, my family has been a big support. My husband is also a physician, and sometimes being in a dual physician family, it can be hard to balance schedules between the both of us, but he has been a relentless source of support. And my move to IU Health, where I am now at Indiana University, they have been incredibly accommodating. I have asked for various adaptations and things that I might need to do my job, and they have been very welcoming. My division chair is wonderful and very supportive, and so that's actually been a positive mitigator. So I want to take a second. I know I just alluded to a little bit of the gender disparities that exist in medicine in general, but especially my field of medicine. So up until the 1970s, there were actually very, very few women in medicine going into medical school. There was this kind of seismic shift that women didn't have to be only at home anymore, and there were several women joining medical schools all over the country. Nowadays, almost 50%, if not greater, medical school matriculants are female. This here is a chart that is from the American Board of Internal Medicine, and it tracks all the subspecialties in medicine, internal medicine. And so you can see these are all the subspecialties that exist. GI is here in red. And you can see over the last several years, 2013 onward, we have steadily had about 30 to 40% female matriculants into a gastroenterology hepatology fellowship program. We are not all the way at the bottom. Interventional cardiology, another procedural field, is all the way at the bottom, but we are kind of 5th from the bottom. So there aren't still very many women going into this field. There aren't many women in this field, and there are even fewer women in leadership positions within this field. this is not to make any of the men in this room feel bad, but what does the evidence show for women who are in medicine? The metrics show that patients who have female physicians, that patients that were sicker who had female physicians, in regards to diabetes and cholesterol control, when compared to male physicians, actually the female physicians took better care and controlled and corrected their diabetes and cholesterol better than male physicians. And this was a large study done of over 15,000 patients. Women engage in more preventive care with our patients, so we do a lot more counseling. And we perform as well, if not a little bit better, on all the standardized tests. Not to say that standardized exams are necessarily correlating with performance from a clinical perspective, but this study there have been studies that show that we do better. And typically we provide more patient-centered counseling. And that again has been shown in multiple studies, not just one or two. And this one I thought was a particularly interesting study. If you come to the ER with a heart attack and you have a female ER doc, you are more likely to survive your heart attack. And in general, this was a large retrospective review of hospitalized patients. And if your hospitalist was a female versus a male hospitalist, you were less likely to come back to the hospital within 30 days. So, and there's more. I just presented a few of them. But we do great in medicine. But there's still few and far between in especially procedural fields in medicine and especially leadership positions. So in particular, this is a graphic relevant to my training, my field, so gastroenterology and hepatology. Like I mentioned before, more than half of the medical students that come in are female. But when you get down to internal medicine, it's about closer to 50-50, 44%. GI strongly staying in that 30 to 40% range of female fellows. And then even though fellows are in training, many of them don't go on to practice GI. And so we're losing them somewhere between training and practice. And then as you can see, very few are actually program directors, and then very few are division chairs. And then in terms of GI is a subdivision of internal medicine, in terms of how many of those go on to be division of internal medicine chairs, even less. So what might change the calculus? Mentorship and sponsorship. And so I want to talk a little bit about the significant importance of this. So this is another beautiful recent study that kind of was published that talks about other barriers. So we aren't seeing as many people who look like us in the field of medicine. So we value a workforce that reflects us. And so not only women physicians, but underrepresented minorities, LGBTQ physicians, and then physicians with disabilities. And so how do we increase representation? So a little bit about ableism, which all of you are probably very familiar with. But when I give this talk to medical students and residents and fellows, this is like a new concept to them, right? In medicine, there's this overarching thought in medical training that the perfect person, the person who has no illnesses, that has no disabilities, is the right person to make their way through medicine. It just isn't the case, right? And this very outdated view of kind of what and who should pursue this field is hopefully we're starting to turn the corner and changing people's hearts and minds about this. So there's different types of ableism, right? So when I mentioned that my health system wouldn't even get captioning and it couldn't understand the importance of it, there's institutional ones, right? So they don't understand and they don't want to change the ways that they are to adapt to their workforce. Interpersonal, sometimes we think that we don't deserve to have an accommodation or an adaptation. And it's very similar to the internalized one. It actually took the advocacy that I used for my patients, when I had to turn it around to myself, actually took a long time for me to do that, longer than I expected. That is that internalized ableism that we sometimes have. So I love this quote from a health equity researcher. So doctors and medical students still perceive the clinical environment as hostile towards declarations of disability. This is very true. Even in 2025, medical trainees, residents, fellows are worried to disclose disability, especially those who have invisible disability. And this is, not all of the AMC presidents have been this forward thinking, but this was, Dr. Cohen was. So it's a simple matter of social justice and equity that our healthcare professional community mirrors society, also with the inclusion of physicians with disabilities. So they did claim this just a few years ago. Mentorship and sponsorship. Part of how I am here, a large part of how I am here. This was a big mitigator for me, and I think also for many of my colleagues. So what does this mean? Mentorship fosters through a longitudinal relationship with a mentor, can foster this, you foster a personal relationship with them, and that helps you to kind of further your career. And then sponsorship is somebody who unequivocally believes in you and gives you opportunities and is 100% behind you. And those opportunities may not be as frequent as a mentor might give, or as you may not touch base with them as frequently as you do with a mentor, but when they reach out, they are 100% in your corner and have your back. This is some of my sponsors and mentors. I could give you several slides to kind of go on with them, but these are people who have helped both further my career as well as my personal well-being by being these mentors and sponsors. Dr. Rowe is at Rush in Chicago. She gave me the opportunity to give my first talk on pregnancy and liver disease. That's her area of expertise as well. Dr. Al-Haddad is my division chair and has given me kind of carte blanche support of all the things that I would like to do. Dr. Zecker was my program director at University of Cincinnati, and again, a beautiful human and somebody who was 100% behind advocating for me in any which way I needed to. So having had these experiences, having had my journey, especially in the last few years, I realized I could use my position and my voice to be more of an advocate for those like me. And so I turned some of my experiences into advocacy in different ways I'll tell you about here. So it is a known fact that 1 in 4 adults in the US identify as having some type of disability. People with physical disabilities actually have a 75% higher odds of unmet needs from the medical profession. Having a diverse population that mimics the patient population would benefit healthcare training, as well as ultimately how patients are treated, what access they get, and the quality of care that they get. And so this includes APPs, advanced practice providers, this includes physicians, and these are people with sensory, physical, mental disabilities. The ACGME, which is the American Accreditation Council for Graduate Medical Education. So this umbrella organization in the US covers medical residents as well as medical fellows, has actually have no mandatory disability education curriculum set forth. And so it's not mandated to be a part of any of the training that advanced learners in medicine have. So this led me to do a survey study. The institution I was at before was actually the third largest training program for graduate medical education in the US, with a little bit over 800, 900 learners that we had at that institution. So we did a survey study to look to see what the self-reported prevalence of disability was amongst trainees as well as amongst faculty, and then their perceived and actualized access to accommodations. In the country currently, there are very few studies looking at how many physicians actually are in practice with disabilities. The estimates are anywhere from 2 to 10%. But we think it's likely more. It's just very underreported for the reasons of ableism that we kind of talked about earlier. And again, this is unpublished yet, but so we had almost 200 responses, with more actually faculty responding than graduate medical education fellows and residents. The disability definition that I used was a broad range of physical, sensory learning, intellectual, mental, psychological, and chronic health conditions as well. How many people self-identified? About 11% said that they did have a disability. And again, probably higher, just many did not take the survey or did not self-report. And then how many people knew whether or not their division actually provided accommodations? Really, only half of them knew whether they did or not. And more than half of the people who responded to the survey had no idea how to access any accommodations. And so I was pleasantly surprised that a third almost of the divisions were doing some kind of disability education training for their learners, even though it's not a mandate. And actually, as much as all of us hate taking classes and things to kind of maintain our license or just training classes, almost 92% agreed that having disability education be a mandatory part of their training was something that they would like, which again was a pleasantly surprising thing. What are some of the future directions? So Dr. Lisa Meeks, Dr. McKee, a few other researchers, Dr. Swenner, are huge health equity researchers that are in this field. I think partnering with ACGME to try to get them to actually make disability education be a mandate would be an amazing next step. There was recently, and hopefully it will be maintained, a report from the National Council on Disability that actually laid out in almost 100 pages the different adaptations that medical facilities should have for patients with disabilities, with a wide range of disabilities. And then the Docs with Disabilities Initiative, which I am a part of, the Women with Disabilities in Medicine mentoring work group, and other podcasts and things that they put out, along with all the research that they are putting out, I think is the key to having us start to achieve some equity in medicine when it comes to diversity, equity, inclusion of people with disabilities. So, take-home points, I have a lot of them. Sponsors and mentors can and do act as mitigators for overcoming several barriers. Patients value, we know this, providers they can relate to, so there should be more of us in medicine. Allyship is incredibly important. I have had so many allies throughout my journey. More inclusivity in all the places leads to improved patient care, improved patient experience, improved patient outcome. Studies have shown, and we know, women can do this and do this really well. So how do we maintain women in medicine? And I think that goes back to allyship, sponsorship, mentorship. And I think despite the current climate of minimization of DEI initiatives, this work is underway. It's not going to stop. We are going to continue it, whether funded federally or not. And that is it. I will be happy to take questions. Thank you.
You mentioned that you found sponsorships. How were you able to navigate finding sponsorships? Because you found sponsorships for education purposes, correct?
Yeah, so that's a really great question. I didn't necessarily do anything other than be myself. And I think that some of those sponsors kind of just recognized, well, she works hard and she's done a really great job with this. And then you kind of develop a friendship with them and they trust what you do. And so they kind of were able to kind of reach out to me in times, well, we need a speaker for this presentation, or we need somebody to lead this study. And that was kind of how that kind of came about. But it was kind of continuing to be, just be yourself, be excellent, and that those people will find you and they will recognize that. And I think that's how I've been able to get those sponsors and have them help me, you know, in my career. And even in my personal life.
Are situations in which people reject half a liver, like, do you see worse outcomes with that?
Yeah. So that's a great question. So going back to liver transplant, so we have seen that patients who reject within the first 3 years after a liver transplant might have decreased longevity of that liver graft. So with that said, immunosuppression is so much better now than it was years ago that even if I have a patient who has acute rejection in the first few years, I am able to get them to have their liver and keep their liver in good shape for years and years to come. The biggest landmark study that was done looking at rejection and liver transplant, it did say that if you had many episodes of rejection that first 3 years, it would deteriorate the life of your new liver. The average liver graft, we call it an allograft when it's not your liver that you received, is actually 10 years in the US. So it's not indefinite, but with that said, with very close follow-up, with much better immunosuppression medications, I've had patients live 20, 30, 40 years on their livers. So
thank you so much again. We want to give you a big round of applause.